Today we break down the essential of chest CT, from vascular anatomy to pulmonary segments and key interstitial patterns. Mastering the fundamental help you recognize life-threatening vascular diseases, identify segmental pathology, and decode interstitial lung disease with precision. The key vascular structures on chest CT are essential landmarks that guide accurate diagnosis in thoracic imaging. When reviewing a scan, radiologists first evaluate the aorta from the aortic root, ascending aorta, and arch to the descending thoracic aorta to detect aneurysm, dissection, intramural hematoma, and penetrating ulcer. The pulmonary arterial system is equally critical. The main pulmonary artery, right and left pulmonary artery, and segmental branches must be inspected for acute or chronic pulmonary embolism and signs of pulmonary hypertension. Venous structures such as superior vena cava, axillary system, and pulmonary veins have identified thrombosis, compression, or abnormal venous return. Additionally, key mediastinal vessels like subclavian, bronchial, and internal thoracic arteries provide clues in hemoptysis, trauma, and vascular variant. Recognizing common anatomic variants, including pulvi arch, apparent subclavian artery, persistent cleft, SVC, or right side aortic arch, is essential for avoiding misdiagnosis. Understanding the vascular landmarks allows clinicians to interpret chest CT with higher accuracy and confidence. Computed tomography angiography (CTA) of the chest provide essential diagnostic criteria for a wide range of aortic and pulmonary arterial diseases. For aortic aneurysm, CTA demonstrates a permanent dilation of the aortic diameter, measuring at least 1.5 times the expected normal size for the specific anatomical segment. The contour is usually smooth and mirror-thrombus may be present in chronic lesions. In contrast, aortic dissection is defined by the presence of an intimal flap separating true and false lumens. CTA also reveals distinguishing features such as differential contrast enhancement, the big sign indicating false lumen expansion, and branch vessel involvement, which are critical for Stanford classification. For intramural hematoma, the hallmark is reccentric or circumferential high attenuation for aortic wall thickening without contrast enhancement, typically measuring greater than 5 mm. Penetrating atherosclerosis ulcer present as focal outpouching extending beyond the intima into the media, often accompanied by a transient hematoma. CTA additionally allows assessment of traumatic aortic injury characterized by pseudoaneurysm formation, contour irregularity, or periaortic hematoma regarding pulmonary artery. CTA is the gold standard for diagnosing pulmonary embolism. The key criterion is a filling defect within a contract or pacified pulmonary artery, which may appear as a central defect surrounded by contrast polymyxine, a peripheral defect forming an acute angle with the vessel wall or complete luminal obstruction. The study also reveals right heart strength indicators such as RV-LV ratio greater than 1.0 and dilation of the main pulmonary artery. For pulmonary hypertension, A CTA diagnosis is supported by enlargement of the main pulmonary artery greater than 29 mm or larger than adjacent ascending aorta. Additional findings include pruning of peripheral vessels, septal flattening, and mosaic perfusion pattern. In chronic thromboembolic pulmonary hypertension, CTA is so web, bands, eccentric wall-adherent thrombi, and RF vascular narrowing. Finally, CTA play a crucial role in detecting pulmonary artery aneurysms, typically identified as focal dilation exceeding 1.5 times the normal diameter, with attention to wall enhancement and associated vasculitis or infection. Collectively, these well-established diagnostic criteria help radiologists accurately classify, risk stratify, and guide management for aortic and pulmonary vascular diseases. Understanding pulmonary segmental anatomy on CT is essential because each segment functions as an independent anatomical and clinical unit with its own bronchovascular supply. Segmental analysis allows radiologists to localize disease with precision, improving diagnostic accuracy for conditions such as pulmonary embolism, tuberculosis, and early lung cancer. By knowing exactly which segment is involved, clinicians can better correlate imaging with symptoms, guide targeted bronchoscopy, and plan segment-based surgical resection, which are increasingly referred over lobectomy. In early-stage lesions, segmental mapping is also critical for differentiating diseases that follow anatomic boundaries from those that cross them, such as distinguishing segmental atelectasis from lobar collapse. To interstitial lung diseases on CT, specific axial levels such as the aortic arch, carina, right pulmonary artery, and left atrium serve as consistent landmarks to identify segments. Reducibly, mastery of segmental anatomy elevates CT interpretation from general pattern recognition to high-precision anatomical diagnosis, enabling earlier detection, more accurate staging, and highly tailored treatment planning. Axial chest CT provides a systematic way to understand pulmonary anatomy, and each landmark level reveals a distinct combination of lung segments that help clinicians accurately localize disease. At the level of the aortic arch, the upper lobe dominates the field. The left upper lobe appears as a merged apical posterior segment because the apical and posterior segments are anatomically fused. On the right, the apical segment of the right upper lobe occupies the posterior and superior portion of the lung window. This level is also notable for the absence of lower lobe structure, giving the image of the characteristic high-lung appearance. Descending to the carina, the anatomy becomes more complex. Both upper lobe exhibit their anterior segment, appearing more ventral and medially than the apical segment. On the left, the superior lingular segment emerges just below the carina, forming a distinctive triangular density adjacent to the heart body. This slide is crucial because the carinal bifurcation defines many airway center abnormalities such as tracheobronchial stenosis or lymphadenopathy. At the level of the right pulmonary artery, the middle zones of the lungs become more apparent. On the right, the middle lobe composed of the medial and lateral segment, appears anteriorly inferiorly to the hilum. On the left, inferior lingular segment occupies a similar anterior medial position. This level also begins to reveal the superior segments of both lower lobes, which arise posteriorly and symmetrically, serving as an early indicator when evaluating lower lobe predominant diseases. Finally, at the level of the left atrium, the CT demonstrates the full anatomy of the lower lobe. The superior segment appears posteriorly, while the basal segment, anterior, medial, lateral, and the posterior spread out like a fan along the diaphragm. A symmetry and predictable arrangement at this level make it a key reference point in distinguishing infectious, inflammatory, and fibrotic patterns. Understanding these characteristic segmental appearances across axial slices allows radiologists and clinicians to navigate the lungs with precision, improving accuracy in diagnosing segment-specific pathology and guiding targeted interventions such as bronchoscopy and segmentectomy. Interstitial lung disease refers to a diverse group of disorders characterized by inflammation and fibrosis of the pulmonary interstitium, the network of connective tissue that surround the alveoli, bronchioles, and pulmonary vessels. On CT, particularly high-resolution CT, the interstitium becomes visible when it is thickened and altered by disease. Key features including reticulation, rowlet opacity, traction, chondriectasis, and honeycombing, which have distinguished inflammatory from fibrotic pattern. CT is crucial because ILD often presents with non-specific symptoms such as chronic cough and progressive dyspnea, while imaging reveals the underlying structural damage. Understanding interstitial changes allows clinicians to classify ILD into major categories such as idiopathic pulmonary fibrosis, connective tissue disease, related ILD, hypersensitivity, pulmonitis, and sarcoidosis. By analyzing the distribution, whether basal, peripheral, or polyp predominant, or diffuse, radiologists can narrow the differential diagnosis and guide biopsy or treatment decisions. In essence, CT evaluation of the lung interstitium provides a detailed window into diseases that disrupt the lung microarchitecture, enabling earlier detection and more precise management. On high-resolution CT, interstitial lung abnormalities can classify into several characteristic patterns, each associated with the specific clinical entities. The ground glass opacity pattern suggests partial airspace filling or interstitial inflammation and is commonly seen in early hypersensitivity, pneumonitis, organizing pneumonia, viral infection, and non-specific interstitial pneumonia. Reticulation representing thickened interlobular septa and intralobular lines often reflects early fibrosis and is typical of connective tissue disease, related ILD, and chronic hypersensitivity pneumonitis. When fibrosis progresses, traction bronchiectasis emerges, indicating distortion of lung architecture due to fibrotic pool, frequently observed in idiopathic pulmonary fibrosis and advanced NSIP. The most definitive fibrotic pattern is honeycombing, characterized by clustered subpleural cystic airspaces. This finding is a hallmark of unusual interstitial pneumonia pattern, strongly associated with IPF and often seen in rheumatoid arthritis. associated ILD. Another important pattern involves attenuation caused by air trapping or vascular heterogeneity, which is prominent in hypersensitivity, pneumonitis, bronchiolitis, and chronic and bronchoembolic disease. Crazy puffing, a combination of GGO and interlobular septal thickening, is classically described in pulmonary alveolar proteinosis, but can also appear in ARDS infection and diffuse alveolar hemorrhage. Centrilobular nodules are typically linked to the diseases affecting the small airways or perilymphatic spread, such as sarcoidosis, hypersensitivity, pneumonitis, and smoking-related ILD, like respiratory bronchiolitis associated ILD. In contrast, perilymphatic nodules along the bronchovascular bundles and pleura strongly suggest sarcoidosis or lymphocytic carcinomatosis. By interacting CT pattern with clinical context distribution, symmetry, chronicity, and associated features, radiologists can narrow the differential diagnosis and identify hallmark diseases such as IPF and SIP, sarcoidosis, hypersensitivity, pneumonitis, and smoking-related ILD. Ultimately, HICT pattern recognition remains the cornerstone of modern ILD evaluation because it directly reflects underlying pathobiology and guides biopsy decision, prognostication, and treatment selection.